Hello, everyone. I want to start by thanking you for joining us today. This session is revisiting a common lab test, urinalysis and urine culture. We're that all of us are here today to hear this wonderful presentation from Beth Warning. My name is Mackenzie Ferrone-Waite, and I'm going to serve as your host for this webinar session. So over the course of the next 45 minutes, Beth Warning will discuss the current practices and the analytical testing of urine and the requirements for urine and urine culture. If you have any difficulties with your audio during the webinar, we would like to remind you to please make sure that you're listening through your computer speakers and that the volume is turned up to a reasonable level. If you continue to have difficulties, you can either use your chat feature to message me, the host, and I'll do what I can to help you, or you can use the dial-in information that was on the whiteboard and also provided in the emails coming up to this webinar. You can also feel free to use the WebEx Q&A section as a vehicle to type your questions. You can submit a question at any time, and we will make a sincere effort to respond before the end of the hour. Also, just so everyone knows, when you close out the webinar, a page will automatically open on your browser with the survey for PACE, and once that survey is completed, you will have the ability then to fill out and download your certificate, and you can be assured then that your credit has been passed on for your continuing education. There will be a follow-up email sent to everyone who attends. There's a copy of this recording, a copy of the presentation, and we'll have a link also to that survey if you happen to close out of it or have any issues with it. We will be sending out that information within an hour of the end of this presentation. But before we start the webinar, I would like to take a moment to introduce our presenter, Beth Warning. Beth Warning is a faculty member with the MLS program at the University of Cincinnati. Prior to academia, Beth had extensive experience in large multi-location medical centers, working in hematology, toxicology. I'll get a picture up here for you guys to be able to see her. Over a career spanning 25 years with the same facility, she advanced to laboratory director for the Rural Access and Immediate Response Labs. She is active in promoting the profession of laboratory science to area high schools and serves on both state and national professional committees. She is also an annual speaker at the internationally attended Phlebotomy Supervisors Boot Camp held at the Center for Phlebotomy Education and sponsored by Greiner Bio 1. So I am going to pass the presentation over to Beth. Beth, take it away.
Good, everyone, and thank you, Mackenzie, and thanks to Greiner Bio 1 for the presentation opportunity today, and thanks to all of our attendees. Being in a hospital setting, I realize sometimes it is a little difficult to get those continuing ed points in, so I appreciate everyone attending this afternoon. Let's review our objectives for today. First, I'm going to describe the pre-analytical requirements for urine and urinalysis, and talk a little bit about practices for culture, of how to culture collection. We want to, yes?
I'm sorry to interrupt you. I think that we need a little bit of help seeing there we go, the objectives.
Okay, sorry. And so other objectives, we want to correlate biochemical findings with some select clinical conditions and describe the process of urine culture for select patient populations. Technical difficulties on my end. Okay, analysis is one of the oldest laboratory tests that are performed, and they can provide significant information for the physician. For the patient, it's kind of nice because it is a non-invasive procedure. So let's review when, in good practice, a urinalysis might be necessary. When I discuss urinalysis, I'm referring to the physical, chemical, and the microscopic analysis, and many of us may have reflexes to urine culture as needed, or based on physician recommendation by the patient population and standard practices within the facility. So are they recommended? Has the suspected urinary tract infection, definitely we would do a urinalysis and try to reflex that to a culture. And the physician is suspecting that a patient has a renal-associated condition that would need to be monitored, such as hypertension, kidney disease, renal disease, or recurrent renal calculi. Contrary to popular belief, Diabetes is not listed here as primary diagnosis and monitoring tool for using urinalysis. What we'll use instead for diabetes is the glycohemoglobin testing or the hemoglobin A1C. For pregnant patients, especially if we're looking for toxemia or preeclampsia, other methods of quantitating urinary protein would be recommended. All right, let's start at the beginning. Once the test has been ordered, we really rely on the patient to perform the next steps. These are then influenced by how the specimen is collected and how it's handled in this pre-analytical phase. Relative ease in obtaining the specimen, there might be insufficient information provided to the patient for proper collection. Do a quick poll. Facility provide instruction to the patient for specimen collection and handling. Is it provided, or do you feel that the collection is intuitive and the patient should know how to do the collection? Do you need to work with physicians' offices or outreach sites on how to educate the patient? If you do provide instruction, are your instructions written or verbal? Do they include illustrations? And is it clear to them, based on the patient demographic, whether they're elderly patients or young patients, the instructions? Ideally, we would like to provide instructions in both the written and oral format, and them in other languages based on our patient population. The instructions will be different based on the testing that will be performed. So that leads us to talking about the different types of testing that we will use.
Mackenzie, this is fantastic. We're seeing the poll going here. It looks like we've had about half of our attendees answer at this point. So if we give it just a few more seconds, then I can close out the poll and we can show everyone the results.
Polls throughout the presentation today, so hopefully, you're not taken off guard by the quizzes that we're providing for you today. Simian testing can be accomplished using randomly collected specimens, and the ones that we can collect anytime during the day without prior patient preparation. But influences of daily situations with diet, fluid intake, and patient exercise, the specimen may not accurately reflect the patient's current status. For instance, if the specimen is too dilute, analyte values may be lowered. Instructed to collect a first morning specimen, which is specimen of choice if a microscopic analysis is to be performed. They're generally more concentrated because it's been held in the bladder for anywhere from 4 to 8 hours. This may elevated levels of protein or nitrites if they are present, and cellular elements such as bacteria may be present. Patients and samples should be provided at least 1 day in advance of the patient coming in for the testing, so they have the materials on hand for that first morning void. Also be asked to avoid nighttime bladder voids so that a full collection over that 8 hours can be provided. But this is difficult for the very young or for the elderly. The missing patch collection is the preferred collection for urine culture and sensitivity testing because of the incidence of normal urogenital flora that may cause contamination. This, however, also requires an increased amount of patient education because to instruct them to cleanse the urethral area, to define what a midstream collection is, and then make sure that they're not contaminating the specimen collection container itself. All supplies need to be given to the patient, and this include the specimen container and the cleansing towelettes. Catheterized collection is an invasive procedure, and even though it should be sterile, contamination with normal urethral flora. All the urethral openings should be cleansed with soap and water, and the catheter port should also be cleansed with alcohol prior to insertion. That are catheterized collections need to be labeled as catheterized, especially for culture and sensitivity. Commonly used for measuring analytes such as creatinine, urea nitrogen, glucose, or catecholamines, collected over a specific time frame, typically from 8 to 24 hours. Instructions need to be provided to the patient to keep the specimen refrigerated during that long collection time, as well as instructions on how to collect the specimen. Just a refresher for us, Remember that the bladder is emptied prior to the beginning of the collection. The subsequent voids are collected. As void is collected to be included at the end of the collection time. By Miller, published by Biochemical Medica, that samples were not properly collected in more than half of the informed patients for a 24-hour urine collection, noting that most of the 24-hour urine collections were performed on patients over the age of 65. Another pre-analytical variability lies within the choice of urine collection containers. There are choices for urine collection containers and some include recommendations from the manufacturer on how the product should be used. So I recommend that patient ease, the container should have a wide opening and a wide base to avoid accidental spillage. It should have a minimum capacity of 50 milliliters. The lid should be an airtight cap and leak-proof in order to have secure transportation to avoid specimen loss and other contamination. Stairs, of course, are required for sensitivity testing. Non-collection containers can be used for testing if specimen is to be tested in 2 hours, or if the specimen is refrigerated for 2 to 8 degrees centigrade. And as well as those with low osmolality, can a rapid lysis of urinary constituents. Thus recommended to lyse the urine within 2 hours after collection. Free of specimens for chemical or microscopic analysis or urine culture is not recommended. Okay.
Amber, if you can see this up on the screen now, but the poll results are in, and I believe I've pushed them out to everyone, if you can see them on your screen.
I see them on my screen. Thank you, everyone, for your participation. About some of the new urinary collection containers that are on the market. These are the ones that have the vacuum tube for secondary tube fill. So the patient may collect into the urine container, the 50 ml urine container, but we use an aspirate or an aliquot aspirated into a vacuum tube for the collection. As here, the vacuum systems allow for direct sample aspiration into the tube or container through a shell-like device through collection lid. A study published by Biochemical Medica in 2014, they warned against using these vacuum systems for cellular analysis, as there is possible disintegration of hyaline and cellular cast during the vacuum aspiration. Forced vacuum has been demonstrated to cause the release of cellular inclusions, such as red cells and white cells, from the cell or white cell cast. Delayed preservatives are typically used to help the metabolic changes of the various urinary constituents and elements. This will delay bacterial overgrowth, and with preservatives, we can extend that testing time to up to 72 hours at room temperature without refrigeration being necessary. The different types of preservatives that are used because other crystals may be introduced that will interfere with cellular particle recognition. Preservatives include boric acid or tartaric acid. Boric acid is the most common preservative used for culture and sensitivity testing, allowing the specimen to be held at room temperature, again, until the time of testing. The specimen to preservative ratio must also be observed, especially if you're collecting in an aliquot tube, so to dilute the preservative or to prevent the functionality of the preservative. Specific manufacturer instructions would be noted in making choices for your preservatives. For pre-analytical conditions, the specimen quality will again vary based on type of collection. If we ask the patient for a 24-hour collection, the CSI now recommends a 3-liter container to be used versus a routine standard collection container of 50 milliliters for a routine urine analysis. In specimens, labeling must be used with 2 identifiers, especially if the patient themselves are collecting the specimen and bringing it into the lab. would need to be trained appropriately in the date and time table along with the appropriate two identifiers for our patient. Containers are not recommended unless the specimen is going to be assayed for light-sensitive analytes such as urobilinogen, porphyrins. These are special chemistry tests and not included as a routine urinalysis. Talk about some specific chemical analytes that we could use for our urinalysis. But protein filtration begins in the glomerulus, with capillaries being impermeable to very large plasma proteins. The base membrane of the glomerulus contains negatively charged proteoglycans. The proteins then cross into the tubular fluid in relation to their size and the negative charge. Small proteins, or those with less than a molecular weight of less than 20,000 Daltons, can easily cross across the capillary walls through the glomerulus. However, large proteins, such as albumin, that's 65,000 Daltons, and negatively charged, do not or should not pass through the capillary walls of the glomerulus. It is then defined as urinary protein excretion of greater than 150 milligrams per 24 hours. Protein excretion is found in about 17% of the population, and of that, less than 2% is considered serious disorder. A common finding and require differentiation being benign, transient, or persistent as it appears in renal disorders. When protein is present in healthy individuals, it is considered benign proteinuria and attributed to dehydration, emotional stress, fever, an inflammatory process, or due to intense activity or exercise. We make chemistry dipstick a trace of protein, which is about 10 to 20 milligrams per deciliter of protein, or as a 1+, which is up to 30 milligrams per deciliter of protein. This is normal excretion, and it can be comprised of low molecular weight proteins, such as immunoglobulins. Analysis with the dipstick shows greater than 2+ protein or greater than 100 milligrams per deciliter. This may be considered to be a transient excretion of protein. This recommended that the test be repeated on a morning specimen or the quantitative 24-hour urine be performed. If the follow-up test is negative, then further would be needed. Glomerular diseases are the most common cause of persistent proteinuria, and these conditions can be like minimal change disease, focal segmental glomerular nephritis, IgA nephropathy, preeclampsia, diabetes, viral infections such as hepatitis, and things like lung cancer or GI cancer. Persistent proteinuria is identified in a random urinalysis, meaning over 2 different collections. It is then recommended to do a quantitative 24-hour protein. So analytical variables are present when we're doing protein determinations. Proteins are easily denatured with increase in pH or an increase in temperature. So again, it comes into play with what preservatives are being used or how the urine is sitting before being tested. When used dipstick, the protein is identified using the dye binding method, and this results in a yellow to green colorimetric reaction if protein present. Fall of protein can occur when the urine is highly alkaline, which is greater than pH of 7.5. Because pH would overwhelming the buffer that is present on the reaction pad, we can find a very increased pH in old or stale urine, or if the patient is taking certain medications. Fall can also be seen if the urine dip strip has been overly saturated, it's highly concentrated, again due to certain drugs, which include penicillin or sulfonamides. A positive elevated protein may also be seen if the patient has gross hematuria, because then we'll see a release of the hemoglobin that is being identified on the dipstick. A false positive with the presence of bacteria, with increase in white cells, or with seminal secretions, and due to their increase in protein content. As protein, the key contributions to maintaining glucose homeostasis is significant. includes the release of glucose into the circulation via gluconeogenesis, or glucose from the circulation to satisfy the patient's energy needs. Glucose is absorbed through the proximal tubules. Under normal circumstances, the kidney filters and reabsorbs 100% of the glucose through glucose transporter proteins that are present in the cell membranes within the proximal tubules. 180 grams per day glucose is reabsorbed, with less than 0.5 grams per day being excreted in the urine of healthy individuals. Glucose normally occurs when the threshold for tubular reabsorption exceeds capacity. Typically, blood glucose levels increase greater than 150 to 180 milligrams per deciliter. According to glucose handling capacity of individuals vary based on age, gender, and body mass. For infants who are born less than 30 weeks gestation, glucose is quite common because the filtered load of glucose delivered to the kidney is often too high for the immature nephron to handle. In diabetes mellitus, the most commonly observed condition of glucosuria, as we know, glucose may also be present in acromegaly and thyrotoxicosis, and also in severe illnesses of the liver or the pancreas. About some variables when glucose is present, it's important to note that there are no urinary components identified that have a false positive reaction. So let's see some other dipstick analysis, or the dipstick analysis process for glucose, and some things that cause interference there. One urinary glucose is the glucose oxidase method. This is a somatic method where glucose is broken down to gluconic acid and hydrogen peroxide. Hydrogen peroxide then reacts with the dipstick chromium to cause a colorimetric reaction relative to the amount of glucose that's present. Since this is an enzyme reaction, again, we need to make sure that we're working at optimal pH and temperature in order for the reaction to occur. And for that is between 5.5 and 7, and the temperature should be at room temperature. Acid is the one that we most frequently hear about common interferent for glucose determination. Ascorbic acid will reduce the amount of hydrogen peroxide present in the first reaction. The ascorbic threshold often is due to an excess intake of vitamin C. So the vitamin C intake should be below 50 milligrams per deciliter. The Excretion is a semi-quantitative test used for determining the total reducing sugars that might be present in the urine, and this includes glucose, galactose, and lactose. This test has been widely used for infants to identify these reducing substances that are present as a result of an inherited metabolic disorder. The CliniTest has poor specificity and suggests the presence of non-glucose sugar. It is typically used as a confirmatory test for glucose. Screening is now a standard and mandatory practice for many states to identify common genetic defects and in screening for these common metabolic disorders. So the test is getting virtually Ketone is often associated with glucose. It is the detection of ketones or ketone bodies with urine. Ketone is produced because of fatty acid metabolism formed by oxidation and then released into the bloodstream. Bodies are filterable in the renal glomerulus. They will then appear in the urine. Ketotate is the first liver ketone produced, and this is enzymatically reduced to beta-hydroxybutyrate and then a portion to acetone. The urinary test will detect all three ketone bodies, and a test for beta-hydroxybutyrate is not available for urine. Plasma concentrations of ketones are encountered normally, especially after your overnight fast, but they are negligible in urinary excretion. When concentrations increase above 0.2 millimoles, the excretion becomes measurable, and the ketones will appear in the urine. Ketones present in diabetic ketoacidosis, and starvation or anorexia, and of course indicate serious illness when they are present. Dipstick reaction for ketones is based on the sodium nitroprusside reaction, and again, we yield a colorimetric reaction from pink to deep purple in the presence of acetone or acetoacetate. False positives can be seen in the presence of mercaptoethylene sulfonic acid, which is a rescue drug for quick relief of cancer treatment, and the hypertensive called captopril. Others, such as highly pigmented urine samples, may also cause an positive for the dipstick method for ketones. The test, which is agent tablet test, is a semi-quantitative test, and this also uses the same nitroprusside reaction for ketone bodies to acetic acid and acetone. A 20% reactivity with this type of test, and beta-hydroxybutyric acid does not react at all. This may underestimate the total load of the excreted ketone bodies, with quotation of beta-hydroxybutyrate in plasma being the preferred analytical detection method. The next we'll talk about is bilirubin. Bilirubin is a pigment released with the breakdown of hemoglobin, and it's transported by albumin through the bloodstream, where it's insoluble and unable to be excreted through the glomerular filtrate of the kidneys. Segregated by the hepatocytes in the liver, bilirubin is typically transported out of the body through the feces. However, liver dysfunction, the water-soluble conjugated bilirubin enters the bloodstream and then passes through the glomerular tubules in the urine. Individuals, trace amounts or amounts less than 0.2 milligrams per deciliter are present, so any detectable levels of bilirubin are clinically significant. Bilirubin is present in the urine when there is a bile duct obstruction, liver disease, or liver damage. Bilirubin to be detected before other clinical symptoms, such as jaundice, are present. The small quantities of bilirubin is very important to differentiate between obstructive jaundice, where we will have a positive bilirubin, and hemolytic jaundice, where we will see negative bilirubin. The method is based on the coupling reaction of diazonium salt with bilirubin in an acid medium to color change, typically from tan to pink. Inner substances that may produce a false positive include drugs such as chlorpromazine, which is the name for the antipsychotic thorazine, and act with the diazonium salts to produce a false positive test. The test, a qualitative test used to detect the presence of conjugate bilirubin urine, and use the same diazo method as the dipstick. However, in the recent past, within the last 5 years, this was available from the manufacturer, though it is currently back on the market, but the test was widely discontinued in clinical practice when it was unavailable. The methods for some of these other tests, the clinitest, the test, and the ictotest, it's important to look back at the CLSI recommendations for the urinalysis using approved guidelines, where it is that any confirmation test must detect the same substance, but with great sensitivity in order to be confirmatory. So this brings us to poll number 2. Does the facility use any of the following tests? So this includes the ictotest, the test, both of the tests are being used at your facility, or neither of those tests. So McKinsey has opened the poll, and we have a 5-minute time limit for your responses, just out of curiosity, to see if you're still using these other types of tests that are available. Okay, so we didn't touch on each reagent that's found on the dipstick. Let's switch from chemical analysis to cell analysis through microscopy. Basic methods for preliminary detection of leukocytes, erythrocytes, and nitrogen reduction. It is to confirm the dipstick test with reflex test to microscopy. Microscopy will provide a rough estimate of the cellular and non-cellular elements that are present, and a variety of techniques can be used, such as microscopy, bright field, phase contrast, polarized light, using 100 magnification or 400 magnification, so that's going to vary from facility to facility. If it's used, urine is centrifuged for 5 minutes at 1,500 RPMs or 400 to 450 Gs, and this irrigation will allow for the concentration of the sediment while preserving the cells and casts. The result sediment is then resuspended in 1 ml of supernatant, and the drop is viewed microscopically. Keep it even with centrifugation, a small of the cells might be lost, again, resulting in just a rough estimate of the amount that's present. They're then viewed microscopically and quantitated based on number or relative number that are present, giving either an estimated amount per field or a amount, such as a 1+ or a 2+. Based on an article in MLO in 2012, it was manual microscopy may take up to 6 minutes per sample compared to automated systems. How to perform microscopy? There are methods incorporated into the analyzer, so let's take a minute and look at each of these. Has for many years been associated with hematology, and now it is being incorporated into the urinalysis analyzers, where metaphors are used to categorize cells in uncentrifuged urine. The UF1000I will aspirate the sample, and then the urine is diluted or separated into 2 different volumes, one specific for sediment and one specific for bacteria. In this side of the reaction chamber, the DNA with cells is stained using the fluorescent polymethylene dye. In the reaction chamber, the DNA within the cells is stained using nucleic acids in order to identify the nucleic acids within the bacteria. This utilizes flow cytometry, a laser, to detect the stained particles in the sample at a length of 635 nanometers. The system will quantify WBCs, RBCs, epithelial cells, casts, and bacteria. This is quantified and differentiated based on the fluorescence, impedance, size, light scatter, and size scatter. Each element can then be counted. Results are presented in histograms and scattergrams. It produces the IRIS IQ 2000, and this trademark technique is called automated particle recognition, or APR, where the cells are differentiated and quantitated in uncentrifuged urine again. It relies on differences based on size and shape of the particles and specifies 12 different categories in all: RBCs, WBCs, cast, epithelial cells, bacteria, crystals, mucus, and sperm. These are taken of the particles and by the technologist to be able to differentiate further if there is some confusion. The digital imaging is by the European manufacturer Menarini Diagnostics in the Sedimax. This instrument will use centrifuged urine to produce a monolayer of sediment, which is analyzed by bright field microscopy and digital photography to categorize 15 different particle types based on size and shape of the particle. Analysis is very convenient and efficient, and increase in sensitivity. One difference is that of reporting. With automated methods, quantify the cellular elements present per microliter. There are correlation studies performed to indicate that 5 RBCs per high-power field microscopically are equivalent to 26 RBCs per microliter, and that 5 squamous epithelial cells per power field microscopically are equivalent to about 1.95 squamous cells per microliter. Data is from the IRIS analyzer. They recommend using a conversion factor of 5.5 to convert the automated microliter values to that are observed per high-power field. Although methodology varies, and each analyzer performs the assays at different rates, so say that analyzers can analyze about 70 samples per hour, opposed to a technologist performing the microscopic analysis on every 6 minutes. All right. Let's move to urine culture. The fact that urine is normally sterile, it is a good culture medium. With a 5.5, a concentration of urea, and the presence of other organic acids, find this a nice medium to grow in. Let's talk about the infectious process. The urogenic bacteria have the ability to grow and resist the other defense mechanisms that we normally have in place. They get to the host mucosal membranes in the bladder, villi or fimbriae, and the proteins, such as for E. coli, attack glycoproteins in both colon and the urinary epithelium, they're enabling colonization. Natural bacteria adherence to mannose in the epithelial mucopolysaccharide lining, as well as adherence to neutrophils. If it has pili that are mannose resistant, they do not bind to neutrophils, and therefore they resist phagocytosis. Bacteria also resist our defense mechanisms through the expression of K antigen, capsular polysaccharide. They secrete hemolysin, which can increase in tissue invasiveness. One common uropathogens, Escherichia coli or E. coli, has capsular polysaccharides, hemolysins, and cytotoxic necrotizing factor protein, allowing the bacteria to establish colonization. If without Proteorabilus, which is for its swarming on our culture plates, it also swarms on other solid surfaces, such as catheters, for establishing an infection. Females experience urinary tract infection with far more frequency than males due to the basic female anatomy. The short urethra allows for easy access by bacteria into the urinary bladder. Host defenses, typically the bacteria should be flushed away with urination. Whenever there's any interference, such as sexual intercourse, use of a catheter, or even dehydration, the bacteria then may flourish. Most bacteria find it difficult to survive in the acid pH of urine. The mucopolysaccharide lining of the urinary tract should prevent infection by limiting bacterial adhesion. The body has secretory defenses that help remove bacteria prior to colonization. The insulin IgA, also known as secretory IgA, is found in the kidney and resists the attachment of bacteria. These include normal bacterial flora, specifically Lactobacillus, coagulase-negative Staphylococcus, and Corynebacterium, all barriers against colonization. But if any of these host defenses are compromised, colonization with the pathogen can occur. Three main mechanisms that encourage urinary tract infections. The genital or perigenital area is typically colonized with the normal flora. The process of urination, as I said, flushes the bacteria from the urethral opening. Urethral pathogens will enter the urethra and ascend, reaching the bladder and resulting in infection. Urogenital spread is the most common type of route infection to spread. Hematogenous infection can occur when a pathogen is present in the urinary tract because of sepsis, such as a patient with pneumonia in their lungs. This may sepsis throughout the body. Hematogenous spread is an uncommon cause of urinary tract infection. It may be attributed to Staph aureus, Candida, or Mycobacterium tuberculosis. Infection is most commonly seen in the immunocompromised or the neonatal patient. Ascending spread is similar to the periurogenital spread and is the most common route for a lower urinary tract or a bladder infection. Uropathogens will originate from the rectal area and ascending up the urethra. Commonly seen in elderly patients, patients catheterized, patients that are pregnant or have other urethral obstructions. National Institute of Health, urinary tract infections account for about 8.1 million visits to healthcare providers annually. Especially prone to UTIs due to the anatomic factor of the short urethra, which allows quick access from the bacteria to the bladder. This is most commonly referred to as a lower urinary tract infection, or UTI, or often called a bladder infection. Symptoms such as dysuria, which is urination, of urination, urinary urgency, and incontinence. The specimen may appear cloudy, have an abnormal odor, or present with gross hematuria. Is an upper urinary tract infection and has more severe presentation, when this can include some of the same symptoms as cystitis, but they may also be experiencing fever, chills, nausea, vomiting, increased white count, and flank pain. So infections can develop. Specific UTIs may not present with any of the previously listed symptoms, but instead, we see just a mental status change. This is especially true in elderly patients with indwelling catheters or those that reside in nursing facilities. This is referred to as asymptomatic bacteriuria, and the presence increases with age. Nonspecific symptoms, so the symptoms can include things like fatigue, lack of appetite, low fever. This may provide the differential diagnosis, but they may also be looking at the clinical symptoms for the patient. That suffering from a sexually transmitted infection may present symptoms similar to cystitis, while a patient with stones or renal calculi may also present with flank pain. Appendicitis can also mimic cystitis. Undicated urinary tract infection involves bacteria present in the urinary bladder with elevation into the bladder mucosa, as in cystitis. Urinary tract infection in the patient with various pre-existing risk factors, such as who are immunocompromised or if they have an abnormal structural malformation of the urogenital tract, or that have recurrent multi-drug resistant infections. The asymptomatic urinary tract infection refers to 2 consecutive urine cultures growing more than 100,000 colony-forming units per liter in a patient without typical urinary tract infection symptoms. The presence of asymptomatic infections increases with age and is common for those in long-term care facilities for both men and women over the age of 60. Mind in the urinalysis that can be associated with infection, or what test are we looking for that might reflect to a urine culture? First, of leukocyte esterase on the dipstick, which relates with an inflammatory process, but not necessarily be a result of the bacterial infection. American Urology Association, a leukocyte esterase test has a specificity anywhere from 64 to 94%. Urine is typically present microscopically, which is considered as greater than 10 white cells per high-powered field on a centrifuge specimen. Dipstick, the presence of nitrites in the urine is highly specific for a bacterial infection. Although negative nitrate does not rule out infections. Practice for urine culture may include reference to the nitrite, but this is only of use if the bacteria produces nitrite reductase to make that conversion to nitrates. Let me repeat that. Standard practice for urine culture may look at the dipstick, but we're looking for the bacteria that produce the nitrate reductase in order to give the positive nitrite conversion. Nitrite can also be observed if the dipstick is exposed to air for a prolonged period of time, or if a patient is on medication called pyridium, which is to alleviate painful urination. Hematuria, or the presence of red blood cells in the urine, may also be commonly found, but always found in urinary tract infections. Identifying factors in a UTI is the presence of bacteria from 2+ to 5+ in a high-powered field. Depending if the patient is symptomatic or the patient type. Is the patient elderly, female, or a neonate? Colony counts. Beth began quantitating bacteria back in 1956 using a group of both symptomatic and asymptomatic women with pyelonephritis. This is still in use today, though it has been somewhat modified, and the costs have changed. A cutoff of 100 colony-forming units per milliliter is used to differentiate infection from contamination. Women with pyuria, but no significant bacteria identified microscopically, will have a uropathogen colony count greater than 100, but less than 100,000 colony-forming units. For men, greater than 2 white cells per field, positive leukocyte esterase may trigger the urine culture order. Because of the variations that we've discussed, either by sex or age or the collection method, colony counts will be based on your facility's criteria for ruling in or ruling out a urinary tract infection. Microbiology has moved away from traditional culture and moved toward using innovative techniques such as multi-off, matrix-assisted laser detection to flight, or to real-time reverse transcriptionase polymerase chain reaction. The technology for that has not exploded into bacterial identification for urine. We're taking the specimen directly from, culture directly from the specimen. There does remain bacterial culture using colony counts and organism identification. Some pathogens include Escherichia coli, Klebsiella pneumoniae, Proteus mirabilis, and Staphylococcus saprophyticus. And resistant pathogens have also developed extended spectrum lactomases for E. coli, Klebsiella pneumonia, and Proteus. Head infections can also include organisms such as Serratia, Cystobacter, Enterobacter, Pseudomonas, and Acinetobacter. With lead, routine culture may include a gram stain. The urine culture urinalysis identified presence of bacteria in 10 oil immersion fields. For the culture, we use a quantitative perpendicular isolation technique, 0.01 milliliter calibrated loop for a clean catch midstream sterile specimen, plating them onto 5% sheep blood and also a McConkey agar. Recall the key is selective and differential for gram-negative lactose fermenting organisms. Let's go to poll 3. Just a poll to see which of the following is the biggest issue in regards to urinalysis or urine culture within your facility. So Kinsey has opened the poll. We have 5 minutes to answer what works in your facility, whether it's sample quality, patient compliance, family transport, specimens within departments, or some other factor that presents the biggest challenge for you. Specific patient populations in regards to urine culture. Previously, urinary tract infections are the most common in adult females. This represents most or the majority of the infections. The analysis should reveal a positive leukocyte esterase and greater than 10 WBCs per high power field microscopically. All of the cases will show hematuria, proteinuria, or positive nitrites. One-third cystitis in females is defined as greater than 1,000 colony-forming units per milliliter. Nephritis is identified as being greater than 10,000 colony-forming units per milliliter. For the somatic patient, and it is considered if it is greater than 100,000 colony-forming units per milliliter. Urinary tract infection in women increases with age, and patients are more frequently seen in postmenopausal women due to incomplete bladder emptying or changes in the normal flora, typically due to that of lactobacilli changes. And again, these are some first-line defenses in preventing colonization. More likely to have a recurrent urinary tract, we find as having 2 to 4 occurrences within 12 months, and most commonly caused by reinfection with the same uropathogen, such as E. coli. The recurrent infection again presents as painful or burning upon urination. These are typically healthy and have no anatomical or functional abnormality of the urogenital tract. The biggest factors are sexually active young women, But other factors can include the age of their first urinary tract infection after the age of 15, a mode of urinary tract infection, frequency of sexual intercourse. If complicated urinary tract infection, the patient is treated with antibiotic therapy if the culture has a colony count of 100 colonies per milliliter because the same causative organism as before. Anatomy of the male is considered to be complicated and likely associated with anatomic abnormalities. Infections in adult males less than 50 years old are seen infrequently, but this chance increases with age. Okay, let's review the male anatomy. The urine exits the bladder, passes through the prostate, and then through the penis. Anatomic defenses are in place to prevent the infection and includes the longer urethra in men and distance between the perineum and the bladder. Lower urinary tract disease in men is associated with prostatitis, enteritis, or urethritis. Older men and those with prostatic hypertrophy have incomplete bladder emptying, and the urinary stasis will predispose the patient to infection. Some include dysuria or painful urination with frequency and urinary urgency, along with a fever. Prostatitis is caused by acute inflammation of the prostate gland, resulting in fever and localized pain. Bacterial prostatitis may be caused by inflammatory conditions or autoimmune conditions. Prostatitis may present with few prostate symptoms. It is the most common cause of recurrent urinary tract infections in men. The enteric pathogens are the uropathogens associated with prostatitis. Epididymis is an infection or inflammation of the epididymis. And common pathogens include chlamydia and Neisseria gonorrhea, especially in men younger than 35. For those in the older age group, that would include the enteric bacteria. Associated infections are typically caused in men by a single organism, especially E. coli. American Urology Association, again, in the pediatric population is second only to respiratory infections as a reason for pediatric visits. The infection affects % of children annually, with risk of urinary tract infection at 8% for girls and 2% for boys. In early life or pyelonephritis caused by E. coli. Pediatric population are similar to adults with urinary frequency, urgency, painful urination, incomplete bladder emptying, and incontinence. Non-symptoms include poor feeding, irritability, lethargy, vomiting, and is infrequent. Risk for fungal urinary tract infections if nosocomial infections are involved, such as being catheterized or having an IV, along with being immunosuppressed. Infections are more difficult to diagnose as the child may be asymptomatic. There will be a pyuria greater than 10,000 units per milliliter. The patient has been catheterized. Risks include prematurity and poor nutrition. The child is less than 2 years old with a fever. They evaluated for a urinary tract infection. At this age, the child may still be somewhat nonverbal and unable to express urinary frequency, urinary urgency, or painful urination. What may present are the nonspecific symptoms such as fever, irritability, and lethargy. If it does present with bacteremia, urine monitoring should be performed to identify if a urinary tract is present along with the sepsis. Greater than 2 years old, especially in young females, it is likely to present as cystitis. As toileting becomes more routine, there is opportunity for ascending bacteria along identifying an abnormality or a bowel or bladder obstruction. Other patients include recent antibiotic therapy, which will disrupt the normal flora, or constipation, which places pressure on the bladder due to the rectal dilation. Methods differ also for the pediatric patient in the bladder control and the age of the child. Super aspirations are sterile collections and are performed at guided ultrasound with minimal chance for contamination. Sterilization can also be used, but again, it is an invasive procedure and contamination rates may be high. For children, clean stream collections are acceptable, but they likely need assistance from a parent in order to perform the collection. The use of a PD bag, which is an adhesive sterile bag attached to the child's urogenital area, is never recommended as there is contamination from normal flora that can be present. When in the pediatric patient, the dipstick will most likely be positive for leukocyte esterase, as well as confirmed microscopically by the presence of pyuria and bacteria. The colon on culture again will differ than that of the adult, with significant findings being present at 50,000 colony-forming units per milliliter. And that concludes our presentation. Once again, my thanks to everyone who joined us, and to our host, Griner Bio 1.
So much, Beth. I really appreciate that. I'm going to take the presentation back from you, so we're going to go through just a couple of things here. To answer questions, I want to thank everyone that's with us right now for attending our webinar series, and to thank you, Beth, of course, for such a wonderful presentation. We want to remind everyone that our webinar series will continue through 2016, so keep an eye on our website, and if you haven't already, sign up to receive our emails to ensure that you get the invitations to these and other educational events. You sign up for our mailing list to receive these invitations and other information about Griner products, visiting our website. When this presentation is closed out, either when you leave or when we shut it down when we're finished here in a few minutes, you will be automatically redirected to a survey that you will have to complete for PACE, and then once that survey is completed, it will give you an opportunity to put in your name to receive a download of your certificate. And if more than one person is listening right now under one registration, there will be a link sent to all people who attended and registered for this event to be able to view the webinar again if you needed to, or to be able to access the survey and your certificate. Would you care to see any of the other educational opportunities that we have here at Griner? You can come see Beth speak again. She's going to be speaking next year, this year and next at the Phlebotomy Supervisors Boot Camp. A great opportunity. We had over 100 phlebotomy professionals there last year, and it was a great opportunity. We really enjoyed it, and seeing Beth speak live was fantastic. So if you want more information for that, please contact us. You can sign up to receive our pre-analytic pulse newsletter. It gets sent out every other month with new educational information, and again, you can sign up for that on our website. And also come to connect with us on our social media sites. We have some Test Your Knowledge contests that are going on every month where you can win prizes for knowing things about basic phlebotomy and specimen collection. Finally, before we get to questions, I did just want to take this opportunity to tell everyone about the Perfect Patient Promise program that we've launched this year. It's for new customers. I know that the majority of people on this call probably are already Griner customers, which we very much appreciate. New customers that purchase our Mini-Collect capillary blood collection tubes and the new Lancelino Lancets that we've launched a few months ago, you will have exclusive access to this program, which saves you 5% for 1 year from your first purchase on blood collection tubes, and also provide you with educational materials to help calm your young patients during procedures using Udi the Grinosaurus, which some of you might be familiar with. He is a dinosaur that helps with the order of draw, and we've turned him into a cartoon character that your patient can watch in a video, read a book together with their parents, and then we've also offered several educational tools for those who are actually performing the procedures to be able to use during the process. So enough about all that. Let's get to some of the questions. We are hitting 2 o'clock right now, so we'll get to some of the ones that came up first, and then any questions that we don't get to in the next few minutes, we answer via email so that everyone can get their questions answered. So Beth, you mentioned that if a urine dip is positive for protein, a repeat morning sample should be done. But does that sample have to be done when the patient first voids for the day, or can that be any time during that morning?
The first void is the most concentrated. So if you're trying to identify that protein is present, the first morning specimen, again, protein may be transient based on the patient's diet and fluid intake. So the first morning specimen, if it's present because of a glomerular issue, it should still be present the next morning.
Micro-UA is negative for nitrites but shows bacteria. Is that representative of contamination of the sample or of normal urogenital flora? They have an issue with that in their culture or in their facility.
Coccus saprophyticus is one of the most common urinary pathogens that are present, especially in females. And because it is a staph, it will be nitrite negative. So it's possible to have bacteria present without seeing the nitrate reductase present.
Let's just get one more here. What is the best preservative used in urine calcium test? They're asking specifically, is it 6 milliliters of HCl or 10 grams of boric acid?
That is a great question. At my facility, we use hydrochloric acid, but this may be something that I ought to look in deeper to see for calcium what some of the manufacturers recommend or what some of the recommends are for that, so that we're not interfering at all with the test itself. So I can look into that further and answer that with the email questions that come out at the end of the presentation.
Great. Yeah, and we've got a bunch of people that have put in some questions here at the end, so we will make sure that we get to all of those. We do want to be cognizant of Beth's time and also the others that are on this presentation. So thank you all. Again, we will answer these in the follow-up email coming. We'll give Beth a few days to answer the questions, and we'll get them out to you in a couple of days. Again, some of you are still sharing some questions about the certificate. When we leave the webinar or when we shut it down, you will be automatically redirected. And if for some reason, if the pop-up is blocked on your computer, we'll be sending an email out within the next hour or two to all attendees with all links in the presentation and information that you'll need. So thank you all again so much for attending today's webinar. We hope to see you in future webinars in 2016. Thank you again for such a wonderful presentation. It was fantastic. We really enjoyed it. And we hope that everybody has a great rest of your day wherever you are around the world. And thank you again.